right, good evening, everyone, and welcome to the Prostate Cancer Awareness event hosted by the NAACP Boston branch in cooperation and collaboration with the AdMeTech Foundation. My name is Anthony Crossan, first vice president of the NAACP Boston branch, and tonight I have the privilege of moderating our critical discussion and introducing the speakers that will shed light on this topic. All we do to achieve justice and equity is important and essential. This effort especially hits home because research shows that Black men are 2.5 times more likely to die from this disease. Our hope is that by our discussion tonight, we as men and Black men move with greater wisdom, greater power, and strength to win this fight against this disease. I'd like to recognize our prostate cancer survivors as well, who join us tonight. We celebrate your resolve to champion this fight bravely, and we look to you for guidance and inspiration as we learn from your courage. Thank you for your bravery, and thank you for your resolve, and we stand with you. Now, for the sake of time, I'd like to really just get us started with our discussion by introducing participating legislators who are champions of the prostate cancer educational program for high-risk men, with a priority focus on African-American, Hispanic, and Latino individuals. Representative Tyler, who represents the 7th District, or 7th Suffolk District, is unable to join us tonight, but we are very fortunate to have Corey Jordan representing. So, and I'm not sure, I don't see Representative Holmes. Okay, so we're gonna, I'll turn it over to you, Corey. The floor is yours.
Hello, my name is Corey Jordan. I'm with State Representative China Tyler's office. I'm just here tonight just to represent her on her behalf. Rep. Tyler, of course, represents the 7th Suffolk District, which includes Roxbury, Mission Hill, South End, and Fenway. And I'm just going to say that I'm here, on behalf of Rep. Tyler, and looking forward to a very good discussion tonight. Thank you.
Excellent. Excellent. Thank you. Thank you. And thanks again for being with us. We certainly want to thank the 7th Suffolk District for the unwavering support on this topic and issue. I'll now actually share the floor here and turn it over to introducing Dr. Faina Stern, and president of the AdMeTech Foundation.
Anthony, thank you so much for your partnership. It's a pleasure to work with Boston and NAACP, and it is particularly important to us because, as we discussed, unfortunately, Suffolk County is one of in the 2nd place for Black man mortality of prostate cancer in the state, and 3rd highest for Hispanic men. So we are very grateful for this partnership to address these inequalities. Actually, my presentation was pre-recorded, and I will ask Emma to play it in a minute or two. I'd like to thank AdMeTech staff members who are with us today on Tuesday evening, and this is Thomas Satam and Emma Coyard. In addition, I would like to introduce a new addition to our team, Ron Green. Ron, if you do not mind waving your hand. Ron is a registered nurse, with over 40 years of experience, clinical experience, with passion to serve Black community. And Ron will be helping us with education and counseling of men who will be served through our new prostate cancer equity program that will be described by me. Emma, do you mind playing my video? Faina Stern. I'm a physician and founder of the AdMeTech Foundation. I'd like to express my gratitude to the Boston NAACP for the partnership in this event. AdMeTech Foundation provides leadership for the groundbreaking programs in prostate cancer at the state, national, and international levels. Our programs have been transforming patient care for everyone and reducing health disparities in Black men. The goal of my talk is twofold. First, to review recent and exciting advances in screening and diagnosis of prostate cancer care. Dr. Sean Vason later on will describe advances in treatment. And second, to describe our prostate cancer equity program, launched to bring these advances in patient care to every man in Massachusetts and eliminate health disparities. Prostate cancer equity program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. We are grateful to the members of the Suffolk County delegation to the State House who made this program possible. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. This program was initiated since 2009 in collaboration with multiple organizations and has three components: public awareness and community outreach, medical education, and research. For public awareness and education, we had reached well over 36,000 men since January 2020. While we are dealing with COVID pandemic, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable concern of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits, telehealth, ongoing in-person care, doctor's appointments and testing, and medical procedures such as biopsies and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men in our country. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only about 28% of men remain alive during the same time. In prostate cancer, screening with blood tests called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as Black heritage, family history of prostate cancer, particularly in a brother or father, and increasing age, 50 and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors I just mentioned. Before screening, it is important to avoid exercise or sex, which may impact your testing results for 1 week. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert for further evaluation. For public awareness and education, our messaging centered on the importance of screening and early detection, critical for saving lives. Since 2015, we focused on Plymouth County, which led the state in Black mortality. At that time, Plymouth County had higher than state average disparities. Indeed, Black men were 2.5 times more likely to die compared to white men in Plymouth County. By 2021, we saw over 55% reduction in disparities in death rate between Black and white men, reaching near parity. At this time, Black men are only 1.2 times more likely to die compared to white men in Plymouth County. This is a disparity that is much lower compared to statewide disparity in prostate cancer. During the same time, between 2015 and 2021, there was no reduction in disparities in death rate of prostate cancer at the state level. Recent data from the National Cancer Institute, Suffolk County today has the state's second highest prostate cancer mortality in Black men and the state's third highest mortality in Hispanic men. We are honored to work with Boston NAACP to address prostate cancer disparities in Suffolk County. Centerpiece of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 6th annual conference took place this year between September 22nd and 24th. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices. This educational event showed rapid advances in patient care. In screening, our summit supports clinical guidelines for early detection recommended by the National Comprehensive Cancer Network, consisting of over 28 cancer hospitals and their leading experts. As mentioned, high-risk men, including men with a Black heritage or family history of prostate cancer, are recommended to start screening at the age of 40. Average risk men should start PSA screening at the age of 45. This first or baseline PSA result in younger men has emerged as one of the most important indicators for developing lethal prostate cancer long-term, over 10 years. In diagnostics, we have seen emergence of very accurate non-invasive tools such as blood, urine, and saliva analysis for molecular and genetic markers, and advanced imaging, including ultrasound, MRI, and molecular imaging. This non-invasive diagnostics, highlighting the importance of PSA screening, shifted past concerns about screening for prostate cancer into a dustbin of history. For example, these diagnostics can determine which individual man has an increased risk of life-threatening, rapidly progressing prostate cancer, improve early detection, critical for saving lives, reduce unnecessary procedures such as biopsy and treatment, and optimize selection of personalized care for each man, including careful observation or active surveillance, minimally invasive interventions, or immediate radical treatment. High-risk individuals, including Black men, carry higher risk of both mortality, dying of prostate cancer, and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual man if he should or should not have invasive biopsy or treatment, and what options in clinical care are best for him. Unfortunately, in Massachusetts, Black men are less likely to have precision diagnostics, such as advanced imaging, MRI, or molecular imaging, or genetic testing, or undergo life-saving treatment compared to white men. Prior to undergoing invasive biopsy or treatment, it is important for each man to discuss with his doctor if any testing is available to determine if these procedures are actually needed, and if yes, what kind of options would work best for him. For example, in this slide, magnetic resonance imaging, or MRI, shows prostate cancer lesions and guides biopsy needles with precision. AdMeTech has led research development and large-scale clinical implementation of prostate MRI since 1998. Our summit highlighted the importance of MRI in Black men, who are more likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard blind biopsies performed without accurate imaging. In men with prostate cancer, there are two pillars of the current diagnostics: MRI
and genetics. While MRI shows cancer location and local spread or stage, genetic analysis of cancer tissue reveals underlying biology and probability of progression. Emerging data indicate the importance of genetic testing for many high-risk men, Black men in particular, for selecting the most effective treatment. With this precision diagnostics, we can now accurately determine if each individual man has a slow-growing, what we call harmless prostate cancer, or needs a careful observation, or an aggressive version of prostate cancer requiring immediate life-saving treatment. More recently, molecular imaging has been shown to play an important role in staging of prostate cancer, including presence of metastatic spread and detecting return of prostate cancer after treatment. For example, PSMA molecular imaging has been approved by FDA within the last year and become available at the Dana-Farber Cancer Institute since August 2021. On the left, right here, we can see a traditional bone scale showing no metastatic spread. However, on the right, in the same patient, molecular imaging demonstrates extensive metastasis. This information is important for selecting appropriate and effective treatment. We are proud to have led research and development of molecular imaging since 2001. Based on the evidence coming from military medicine, from veteran administration, our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and NAACP New England Area Conference with their multiple branches located across the state. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. Any Massachusetts man age 40 and older can participate. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsy, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how a physician like me takes care of my family and friends. This process consists of 3 components. 1, AdMeTech Foundation's coordinator collects basic information and matches individual patients' needs with the appropriate state's experts. A clinical organization designates a patient navigator who works with multiple schedulers to expedite a medical visit.
If an expert recommends any next steps, for example, additional testing or treatment, AdMeTech's coordinator and patient navigator work with men on the appropriate follow-up. To ensure successful implementation of this program, AdMeTech has created a network of leading state experts committed to eliminating health disparities, develop an effective process for patient care and follow-up, as mentioned, recruited community coordinators in high-risk areas who mobilized a network of over 100 program ambassadors, community, organization, and church leaders, held multiple focus groups to develop program materials. Our current goal is to identify and mobilize appropriate organizations and individuals so that men, their primary doctors and caregivers have access to this program. Trisha Keeney, a member of the AdMeTech Foundation staff, serves as a statewide coordinator for the Prostate Cancer Equity Program. If you have any questions or need assistance, please contact Trisha by phone, 617-523-3535, or by email, coordinator@admetechfoundation.org. Thank you for your attention.
Stern, thank you for that information. Extremely informative. If you're tuning in, I hope you are taking notes. I don't know what type of student you are. I know that it's important for me to take notes. I can overlook some things and miss some things that are important. And so we will have some time to recap. And I think it's important here to note that this recording will be available afterwards. So you will have an opportunity to come back to the information and take note in a way that will be useful. But thank you for sharing that information. Would you like to share anything else before we move on?
No, we can address questions later on. Thank you.
Thank you. Yes, so now as we continue on, I want to introduce Jose Javier, participant in Prostate Cancer Equity Program. Jose?
Thank you, Anthony. Thank you so much. And thank you, Dr. Stern. I know we're on a tight schedule, so let me try to be really brief. I know I have a few minutes, and I want to touch a few things. Like Anthony said, my name is Jose Javier, and I have the pleasure to meet Dr. Stern through a friend of mine at church. So those would be the bullet points. The key word there is church, a community gathering place where there is trust to open these conversations. So a friend of mine by the name of Victor McCain, who was supposed to be here tonight, was the one that introduced me to Dr. Stern, and we since then have become friends. Victor had the courage and the openness and the education to be able and being secure enough to be able to share it in front of the church, because it takes courage. It sounds easy to talk about this in this platform where everyone is a professional, a doctor, experienced in some direction, but when you have no experience, it's very difficult. And I remember when he spoke about it, being embarrassed for him, and not to know that very soon I too get tested and find out from my doctor, and that's how the conversation started. So what I'm trying to say is that by my brother at church being caring enough to share his story of being diagnosed and knowing where to get help, where to get the education, having the foundation and the relationship with Dr. Stern and the foundation, I was able to benefit from that. And there I too ended up having it and being able to get there very early. So I'm very blessed to let you guys know. I'm very fortunate to have had the right people around me, the support team. And that's why I'm passionate about being able to come on and very grateful for the opportunity. Thank you, Dr. Stern, for allowing me to share for a few minutes. Another point that I wanted to emphasize on is coming from a Latino Hispanic background. I'm an immigrant born and raised in the Dominican Republic, came to the States, to Lawrence, Massachusetts as a teenager, 11, 12 years old. But being raised in a family where these conversations just don't occur as a teenager, or as an adult, or any level. And if it ever is brought up, is really at a very immature level where it's mocking and making fun of. So the intimidation is inherited as a young person. Therefore, it's never brought up by anyone that I had any experience with. That's why I'm passionate about talking about it, and especially in the private side. It's just talking to people one-on-one and that kind of thing. Because my father also had it and passed away of cancer. It started with prostate cancer. So that's one of the reasons why I think it's extremely important to share it. So those are the two areas. And I know that we talk a lot about, Anthony mentioned some numbers when he's talking about 2.5 times more likely to when you're Black, African-American, and Latino, we would add. The numbers are pretty similar. And Dr. Stern talked about that a little while ago. So I want to thank all you guys, the doctors, Dr. Stern. I wanted to keep it brief because I understand we're on a tight schedule. I don't know if I can go a little bit longer or if you need me to, but the point I'm trying to make is that the education is here. If you want to learn more, you have an unbelievable support team with all the members here and with the foundation, and I have already referred some people to this program, and I will continue to, as long as I can talk and walk, we'll continue to do that. And it's extremely important for us to continue to passionately share this information, because especially to everyone, but especially in those two communities that were highlighted, I think it's extremely important to continue to do this and continue to have these kinds of conversations. I wish there were, I don't know if these are intended to have a big attendance on recorded section. So thank you so much again, Dr. Stern. Thank you to every one of you guys. And I don't know if I can answer any questions or you'd like me to add anything. Thank you.
Thank you so much, Jose, for trusting us. Thank you so much for trusting us, not only with your own well-being, but also members of your family. And Jose went through our prostate cancer equity program. Jose, do you want to comment what your experience was with physicians we referred you to?
Yes. So I thank you, Dr. Stern. You referred me to the NIH, and I was welcome over there with open arms, and it was an unbelievable experience. I felt that everyone, from the minute you walk in the door, they understand the conversation, and they're very sensitive, and it was amazing. The staff, the doctors, the whole process, because it's usually a very uncomfortable process, but I felt very, very comfortable, let's say. They make you feel comfortable, the way that the way it's designed to remove a lot of the fear by them being very, very candid, very human, letting you know that they are your support team. They are the experts, and they're passionate to serve you. That's what I got out of it. That's part of it. I mean, I can talk all day about this, even though I'm being sensitive to your time.
Did you find the team members, particularly at I referred Jose to National Institute of Health about 10 years ago. At that time, NIH had the best technology available and the best diagnostics and therapeutics. And in addition, NIH offers free care to American citizens. So we are still working with Dr. Peter Pinto. Dr. Peter Pinto, who took care of you at the National Cancer Institute at NIH, actually one of our physicians. Did you find Dr. Pinto and members of his team responsive and attentive to your needs? Did you feel alone or struggling alone, or people were not responsive to you, or difficult to reach?
If you want a one-word answer, yes. Yes, very, very, very much so. And that's what I meant when I said from walking in the door to going through the entire process, Dr. Pinto being the last The second last part of the process, he was amazing. By me telling him, I know you don't like getting praised, but when I told him that I was sent by you, he got all excited and passionate. It felt more like a teammate, a basketball player on the operating table type of thing, you know? So we had that type of conversation. So it was fantastic. He has an amazing team around him. They make you feel extremely comfortable with these uncomfortable procedures. And I'm not really, I'm a very fortunate person that I never really been ill or in hospitals and that kinds of things. So that was one of the few times. And I can tell you, I was scared because you walk into something that you have no clue. It's just clueless. And all you have is God's faith and the doctor in the doctor's hand right there in a very vulnerable position, you know, but they made me feel extremely comfortable. Everyone was sharing with their own way, their own knowledge, the process, and, you know, and making me feel comfortable, holding my hand in case something was going to be painful. It was really, you know, under the circumstances, a great experience, to put it that way. I don't know, you don't want to tell people that it's a great experience to go through the process, but it was painless. It was, it felt really great. I can even tell you this part, that last piece, because you know, when you go through that and they got to wait for you to be able to go and urinate on your own, I actually passed out in the bathroom. I was trying to be a little bit too macho and trying to rush it a little bit. I don't think I've ever said this before, but I passed out. And as I was passing out, everything blanked out, and all I can remember when I went to the bathroom is that I remember being aware that something was going on, and I'm a very private person. I had locked the door, and I went and unlocked it, and that's the last thing I remember. And then I just remember some, you know, the nurses attended me and asking me questions and helped me up. And afterwards, we had a good laugh, and they explained to me what happens with your bladder, when, and, you know, and so forth. So it was a great experience. I'm long-winded. You don't want to ask me too many questions.
Jose, you're not the only one that it happens to.
I really appreciate your sharing all of this information, because it is important for us that men feel they're being taken care of, and they can always reach out to someone and talk to someone. It is just as the process of care is just as important to us as the quality of care. Thank you so much for sharing your experience.
Thank you.
It lets us know, I think there's several things that you've talked about, you know, in the role of the church in the faith community, and bringing, you know, resources to those who attend. I think is really important, because that's what we are. A lot of us are there over the weekend, you know, and thousands are there, and to be that accessible, and for you to be courageous enough to go is really huge. So thank you again. Thank you for sharing, and we'd love to hear from you again.
Thank you. And if I can add a couple of words. Now, as Dr. Stern was alluding to, that they had the best doctors in Dr. Pinto and the best technology at that time in Maryland, at the NIH. But now it's here, and Dr. Stern can expand more on that. Now you have it in your backyard. You don't have to go to Maryland. We have the best doctors here. We have other doctors. I don't want to start throwing names, but Dr. Stern knows and has a relationship with each one of them, and we have them in our backyard, and we have the technology. So is confident to be able to say that if
so much.
I would have been now, I would have went here instead of going over there.
Yeah, thank you so much.
Yes, thank you.
So we still, National Cancer Institute, it still is a backup option for us in case American citizens, men, do not have insurance for some reason. In National Cancer Institute, Dr. Pinto served as a backup option for men who do not have insurance, for example, in Massachusetts. And of course, one of the great Massachusetts doctors, experts, is with us today. It's Dr. Sean Vason.
You were too sweet. I agree. I spent some training in DC, and the NIH is fantastic. Same with Dr. Pinto. So I think Emma's going to pull up my talk. But I wanted to give a talk today on and just kind of put everything in full circle. You touched on a lot of the things that I was going to talk about in my talk today, but I just want to sort of hammer a few of the points home. So next slide. Really no disclosures this evening, other than my grandpa. Prostate cancer has touched my family. This is my grandpa. He grew up in Barbados. He died in 2004 from metastatic prostate cancer. I was actually recently in Barbados with the family, and I actually was given a talk, and the one urologist who was on the island who took care of my grandpa was in the audience, and it was great kind of talking with him about the care that he received there. And I think that he really didn't have much of the, the early detection that we have here nowadays. And I think, had he have had that, things may have been a little bit different. So I wanted to go over some of the objectives, really, how do we screen patients? What are the goals? Who do we screen? When do we screen? Why? How do we actually make the diagnosis of prostate cancer? What are the imaging modalities that we're using? Some of them are old, some of them are new. And then really go over some of the basic treatment options that men will likely face with prostate cancer. So what is the prostate gland? It's a small, really walnut-sized gland. It kind of sits tucked in between the bladder and the rectum. Usually it's about 30 grams, but it can be as large as a grapefruit. I see men with a lot of lower urinary tract symptoms, and typically it's from the compression of the prostatic urethra by the prostate gland, but it can obviously cause a lot of trouble. Really, it functions as a reproductive organ, and then it contributes to liquefying semen. And really, some of the prostate cancer goals is really early detection. Prostate cancer, as you know, affects 1 in 8 men in their lifetime. And we really want to maximize the detection of intermediate and high-grade cancers. And I think that this is really important, because over the last 20 years, we've looked at prostate cancer quite a bit differently. And it used to be that everybody with prostate cancer got treatment, which was typically surgery. But now we recognize that we don't need to treat everybody with prostate cancer, and there are different types of prostate cancer. We really want to minimize the detection of non-life-threatening cancers, and then really decrease the unneeded biopsies and treatment for a subset of men with prostate cancer. We have the early detection of prostate cancer. We have a phenomenal society, the American Urologic Association, and there's a whole guideline just based on early detection. Really, it's detection of a disease at a phase before someone would typically have any symptoms or really seek medical care. It has really 3 main recommendations. Routine screening of men under the age of 40 is not recommended. So occasionally we'll see men that are, 39, 35, really prostate cancer screening is not really for this particular age group. The ones that get the most value are those in between the ages of 55 and 69. And you really should have a discussion with your primary care provider, your urologist, about the risks and benefits of screening. If you had only a couple years to live, there probably really wouldn't be much value for PSA screening. So, we look at, do you have at least a 10-year life expectancy? For, routine patients over the age of 70, routine screening is not always recommended. So how do we find prostate cancer? I think PSA gets a bad rap. PSA is really only from the prostate. We do perform a digital rectal exam. So usually the combination of those two will tell us, who are the patients that we need to perform biopsies on. Typically, PSA and digital rectal exam are done screening. But really, you really need the prostate biopsy to make the diagnosis. So what is PSA? It's a protein in semen that liquefies the ejaculate. I guess the good news is that it's only actually produced by the prostate gland. But the bad news is it can be elevated in a variety of different reasons. Some of those are what we call BPH, benign prostatic hyperplasia. As you age, the prostate gets a little bit larger. So it's made by the prostate, which is good, but obviously there's a variety of different reasons why the PSA can be elevated. We use PSA really in screening, diagnosis. We've treated patients with surgery for prostate cancer. We follow the PSA. and even in patients with advanced metastatic disease, and we're able to kind of follow the PSA. So it's good to know what your numbers are. And I think that in this regard, it's a very useful biomarker. From our perspective, I think mass screening is in the past. PSA, we know, has several limitations. Shared decision-making is good. And then there are high-risk patients, obviously a lot that we've kind of talked about today, family history, African-American men, men with BRCA1, BRCA2 mutations. These are all sort of high-risk individuals that really should be counseled on screening. And then the age and comorbidities will often dictate who we screen. PCPs will dictate, who gets screened, and then urologists are really dictating who gets biopsied. So I think if you have a PSA and a under one normal digital rectal exam, you can kind of delay the further screening for about 2 to 4 years. If it's in between 1 and 3 nanograms per milliliter, you can repeat testing at a closer interval. And then anything over 3, 4, anything with a suspicious digital rectal exam, these are the patients that should be referred to urology. And then these are the patients where we'll consider a multiparametric MRI, biomarkers to really substratify these men, those at risk, those are not. Oftentimes in the office, we can do a transabdominal ultrasound just to get an accurate size of the prostate. And I think that the larger the size of the prostate, the more PSA will secrete. So if you have a marginally elevated PSA, but a very large prostate, most likely that's BPH as opposed to prostate cancer. But this can be done either transabdominal or transrectal quickly in the office. If we are going to do a biopsy, it'll be one of 2 routes. The transrectal route is the most common, but we recognize that smaller risk of infection with the transrectal route. So I think there's a lot of centers that are pushing for the transperineal approach. And sometimes this will require just sort of a heavier sedation to be done, but it virtually eliminates the risk of any urosepsis or bacteremia, bacteria in the blood. There's a new sort of modality of ultrasound. I was fortunate to be at an institution where we were one of the centers where we actually studied this particular ultrasound, and it's a high resolution ultrasound probe. It really gives phenomenal ultrasound pictures, and they've come up, if you click to the next slide, there's a grading system 1 to 5, and just based on the ultrasound, very similarly to what we're doing with the MRI, there you can find very suspicious lesions. And this, there's some early studies showing that this may supplant MRI in following patients, because we recognize that MRI is expensive, and this is something that the urologist can do in the office in real time. So not, some centers are doing it, but you may hear a little bit more about micro ultrasound. How do we do the prostate biopsy? Typically it's 12 cores, 6 on either side, and then we're able to give the volume of cancer in each area. What is the aggressiveness? What is the location? And if you click to the next slide, there's a new grouping, and it really, we're trying to use the grade grouping 1 to 5 as opposed to the Gleason score. That you'll still hear the Gleason score, which is a measure of how aggressive the prostate cancer is, but you may also hear grade group 1. We really wanted to simplify it for patients. We really don't see any, Gleason 5s or less. We really try to just talk about 6 and above. And like Dr. Stern said, there's a lot of studies that have been done about multiparametric MRI. Typically, this is done with a 3 Tesla magnet. You don't need the transrectal coil anymore. We get phenomenal pictures. We're really trying to push to get MRIs done before a biopsy, but not all insurances will cover it. So if you're diagnosed with prostate cancer, most likely you'll get an MRI at some point, but it gives you a lot of information about the local extension of the disease. Are there lymph nodes involved, bones involved? And if you click through a couple of the bullet points, it just kind of goes over some of the things that we are able to pick up with the MRI. There's a PIRAD scoring system, so it's important if you do get an MRI, really to get a copy of the report and take this to your urologist or treating physician, especially if you have like a PIRADS 4 or 5 lesions. These are lesions that really should be biopsied. We don't routinely recommend biopsying the 3 PIRADS 3 lesions, but definitely the 4s and 5s needs a biopsy. And then, the anatomy of the prostate is quite variable. And sometimes you'll see these lesions in the front of the prostate that may not be accessible with the typical standard biopsy that we do. And the one nice thing that we're able to do is we're able to combine the ultrasound with the MRI and really fuse these two modalities. And really, this has been a game changer because we're able to really identify these intermediate and high risk diseases in patients that otherwise may have had a negative standard biopsy. We still combine the standard biopsy with the templated biopsy with the fusion with these fused lesions. And so if you're going to get this approach, you're going to get a little bit more of the biopsies done, but the trade-off is that you're less likely to have biopsies down the road, and you're going to get a lot more information. So we know that prostate cancer is really a wide spectrum of disease, and the NCCN has different risk categories. If you just click on the next bullet point to the very left, there's really 5 risk groups, and those range from very low, intermediate, high, and very high risk disease. And then really this algorithm tells us what to do next, what type of imaging is necessary to really work up patients that have been diagnosed with prostate cancer. We are using a little bit more biomarkers. Sometimes this is from urine, sometimes this is blood. And really, we're using this to risk stratify patients. Some patients with low risk disease may have some aggressive features on biomarker, which we may want to surveil these patients a little bit more closely. And we're using them in all aspects of patient care. It's not for everybody, but you may hear of biomarkers, and there's a couple of names out there. Here, this is one of the tests that we use, Oncotype DX, and especially in patients that have very low risk disease, we could send a sliver of the tissue off to this company where they're able to determine what is the biologic aggressiveness of this prostate cancer, what is the risk that someone may die with prostate cancer or have metastasis. So it really confirms or refutes our initial suspicions about certain patients. Additional imaging after biopsy, really there's 2 modalities, CT scan, and then the other one is a bone scan. We still use CT scan quite a bit. Usually it's combined with the bone scan, which looks for disease in the bones. On the next slide, we are using PSMA a lot more, especially in Massachusetts. And anyone with an aggressive form of prostate cancer, will likely get a PSMA. It picks up disease outside of the prostate gland, and we use a radio tracer that's really goes through the blood, and it's bound to PSMA, prostate membrane specific antigen, and then you do what looks like a CAT scan, and these areas really light up throughout the body. And so patients that may have been a candidate for local therapy, we may find metastatic disease, and they may not be a candidate anymore for local therapy. And then how do we do if patients are diagnosed with locally advanced prostate cancer? There's really a couple different options. You can remove the prostate, you can give it radiation, and there's some patients that we're comfortable with just performing active surveillance, so not immediate treatment, but we watch you very closely. So for patients with very low and low risk disease, Gleason 6, typically active surveillance is recommended as the first line treatment. So we watch you, we follow the PSA, we do digital rectal exams, we may use some of these biomarkers. So we're a lot more comfortable surveilling a lot of men. We do this because we know that, there are side effects of prostate cancer treatment. The disease is pretty slow growing, and, someone may not be very healthy, have a low life expectancy. And so it may be okay to watch some of these patients, and it really avoids some of the side effects, but it doesn't prevent you or negate any treatment down the road. So if there's any disease progression to a higher grade disease, then surely you're still within the window typically to undergo treatment. Men always ask me, if I go on active surveillance, can it grow or spread? But we follow you pretty closely, and that's few and far between. And then patients that have intermediate risk disease, really your options are surgery or radiation, depending on how healthy you are for surgery. Typically, men under the age of 70, we try to steer towards surgery, especially if they're in good health. And the men over the age of 70, we tend to steer towards radiation, but it's not clear cut. There's different types of radiation that I won't get into, but really there's the external beam type and then the seeds that are implanted into the prostate. Sometimes there's a combination of the two. And then there's something called CyberKnife, which uses almost higher doses of radiation at smaller fractions. But really what you can expect is that you go in to the radiation oncologist for several weeks, Monday to Friday. And then this is just kind of showing that we really want to minimize radiation damage to other structures outside of the prostate. And so they're able to use this intensely modulated radiotherapy. This is brachytherapy, putting implanted seeds into the prostate, which gives a local dose of radiation that dies off over time. In order to minimize damage to the rectum, we're placing sort of a hydrogel that dissolves in a couple months, and then this elevates the prostate off the rectum. And you may just hear this in your treatment for prostate cancer if you're getting radiation. This is an outpatient procedure. It takes about 20 minutes or so. There are side effects of radiation that we know about. Fatigue is probably the most common, but irritative voiding symptoms, so kind of burning, urgency, frequency to go to the bathroom is very common while you're getting radiation. Down the road, it can affect the erections. And then if you've gotten radiation up front, it's kind of very difficult to then do surgery afterwards. But the flip side is true. You can get radiation after surgery without any problem. And then for men who choose to have the prostate removed, it's called a prostatectomy. Nowadays, just like we were doing in the NIH, the prostate's removed, use kind of keyhole incisions. We're using the Da Vinci robot. And not everyone's a candidate for surgery, but I would say that this is probably the standard throughout the US. Surgery takes about 2 to 4 hours. Recovery is relatively quick. Most men stay the night and then they go home. Catheters in for about 2 weeks and removed in the office. And then depending on, how potent you are beforehand and your disease features, we kind of determine whether or not you're a candidate for nerve sparing or non-nerve sparing therapy. High intensity focused ultrasound has been FDA approved in this country. There's not very many centers that are doing HIFU. I would definitely go to a urologist that's done a high volume of these procedures, and not everybody is a candidate, but it's another treatment option that some men could consider. We've had this, phenomenal talk by Dr. Klotz from the University of Toronto, and how do you be proactive? Number one, smoking cessation. Ask your doctor about a low dose statin, consider vitamin D supplementation, and then also ask your primary care doc about metformin nowadays. But all of these have really shown to kind of reduce the aggressiveness of prostate cancer in one study or another. So in summary, prostate cancer is common and the aggressiveness is variable. We really want to detect prostate cancer as early as possible, so definitely get screened. We want to maximize detection of intermediate and high-grade cancers, and then really minimize the detection of non-life-threatening cancers. We're using new imaging modalities, genomics, to risk stratify a lot of our patients, and this has really allowed urologists and patients to be a little more comfortable with active surveillance. For very low and low-risk disease, consider active surveillance. For intermediate and high-risk disease, really the standard of care is surgery or radiation. And then there are other treatments that are becoming a little bit more common to really minimize the side effects of treatment. So thank you for your attention. I know there's a lot of material to cover. If you're looking for more information, if you just kind of click on the next slide, there's a QR code that brings you to a lot of the information that we have on prostate cancer treatment, which just a great patient information site. Thank you.
Thank you, Dr. Wason. And it's amazing to see how far we've come. Diagnostic measures and these sorts of things that we have to help people really see this thing through. So thank you. I think up next here is Dr. Stern. I don't know if she's still around.
Absolutely, I'm right here. And I did not see any questions in the chat. Do we have any questions from the Facebook? Thomas? Oh,
Can I-
Rob, please.
I have a question. How does the metformin work?
Yeah, it's we recognize that there's I guess in our diet nowadays, there's a lot of carbohydrates and sugar, and we overwork our pancreas, and really it's by that mechanism which really reduces insulin resistance. And there's a lot of studies that are just linked obesity with cancer. And if you can reduce the obesity rates, then you can really treat a wide variety of cancers.
Good evening, all. First of all, thank you for doing this. For those who don't know, I'm Erica Florence. I'm chair of the health committee for the NAACP Boston branch, and also on the executive board. So I love the fact that you all are doing this for our communities, especially for those communities that are impacted the most. But I was curious if it is that the numbers are so high in terms of those that are dying, have there been any discussion around lowering the age for screening, or does that not seem to be a factor? Is it just a matter of lack of knowledge, or do we have to take another look at our primary care teams?
With a couple of answers to your questions. First, different organizations have different guidelines, but I think overall consensus among experts is that high risk, particularly we align very much with National Comprehensive Cancer Network, consisting of over 28 leading cancer hospitals and their, world experts. And they actually recommend for men who have risk factors, such as, for example, Black heritage or family history, let alone of prostate cancer, let alone, family history and Black heritage. They actually recommend to start screening at the age of 40. There is no data. I agree with Dr. Vason, though. There is no data to support screening in men younger than 40, healthy men younger than 40. What else we know, Erica? Your question is as usual right on. There was a multi-center clinical evaluation with primary focus on African-American men in their 40s and their 50s. And what the study demonstrated is that Black men in their 40s had much smaller volume prostate cancer. Prostate cancer was detected much earlier compared to the Black men in their 50s. So screening of Black men in their 40s is really important. If you have a double whammy, Black heritage and family history, you should not be screened. You should be screened at the age of 40, not older.
And I would say that they've done some cadaveric studies on men who have died from trauma, and we do find prostate cancer in young men, Black and white, that died in their 20s and 30s. But we really want to look at clinically significant prostate cancer. We don't want to overdiagnose, a variety, a lot of young men with low-grade disease, and I think that PSA and prostate cancer anxiety is real, and we really want to focus in on the patients that are really going to get the benefits of treatment, and they tend to be a little bit older. But how do we simplify our message to the primary care providers? I think hey, one PSA at the age of 40 is very reasonable. Nice study showing that if the PSA at that point is less than 1.5, you don't need to check it for another 5 years. But if it is a little bit larger than that, those are the ones that should be referred to urology. So how do we get a simplified message to our primary care docs? That may be an option.
This first PSA, what we call baseline PSA test, is very, very important in young men, because right there and then it gives us an idea of the risk this individual man has of life-threatening prostate cancer. And it is, thank God, it's a small minority of men. 80%, roughly 80%, 75-80% of men will have PSA level, baseline PSA test that indicates very low risk, and they do not need to be screened more frequently than 2 to 4 to 5 years. But men who have higher PSA, that's the group you want to focus on, and you want to survey them probably at least 1 to 2 years to catch cancer early. Yes, Jose?
Yes, you mentioned Black men with Black heritage. And I know you always also mention the Latinos. Does that go for the Latinos as well?
Absolutely, Black Hispanics.
I wanted to highlight that.
According to the way, for example, National Cancer Institute classifies men, they actually, the most data they have is Black, including Hispanic men. So Black men, including Hispanic men, when we're saying Black men, it includes Hispanic men.
Yes, I have a question around, I think when we consider the unprecedented numbers for men of color, as we're talking about Black and Latino men and Hispanic men, and sort of that demographic and what we're dealing with, I think there's also a correlation between some of the access to healthy foods that we have, some of those things, and how, you know, sugary sweet beverages and those sorts of things are more prevalent in our community. Is there a sort of a preventative strategy that considers the diet and the healthy lifestyle or practices that we have that we can do to interrupt that or push that out farther because of some of the things that we do?
There is an indication. There is not much data, but commonsensically, heart healthy diet, whatever is considered heart healthy diet and exercise, of course, it is encouraged. And as Dr. Vason already pointed out, obesity does not help. Sean, do you want to comment on diet, exercise, lifestyle?
Yeah, I would say that all three are very important. I think that, it starts with the diet, and, I worked at Boston Medical Center for the last 5 years, and the options kind of right around there, limited, McDonald's on the corner. I think obviously it's another epidemic that's affected the US. Obesity, the rates of childhood obesity is just absolutely scary. But anything that is heart healthy. So you really need 30 minutes of cardiovascular exercise at a minimum, 3 times a week. Really focus on decreasing the carbohydrates, just eliminating the unnecessary calories from the sugary foods that we eat.
But once again, we don't have a lot of strong data supporting lifestyle changes. What we do know, blood test PSA saves lives. Any other questions? Anthony, back to you.
Well, thank you again. As we kind of look at all of our speakers, thank you so much for joining today. And on behalf of the NAACP Boston branch, we're very grateful for this time to discuss this very important issue. And definitely want to recognize Erica, who's been at the front line of this health committee, making sure that these things are happening and these events are taking place. I think a lot of information really stood out, and I'm glad that this will be available afterwards for people to watch and take note on. What stood out to me was early detection. I seen Dr. Stern, one of the slides you held up showing a chart that had 100, patients who went through early detection and 100% sort of made it out okay, and versus 22 to 28 who did not. And the difference was early detection. And I thought that that was eye-opening, alarming, and also encouraging, to know that we do have power with early detection. And I also heard, Jose, you mentioning your testimony really stands out, and I hope folks do go back and listen and watch, because there's a lot of power in that. And definitely want to salute you for your courage, and following those steps and being able to share back what we should know about these, programs that are out there that are making sure that care is accessible and treatment is accessible, and early detection is something that we can attain. So thank you all. Thank you so much. If you are watching, please do get another chance to look at what the information that we talked about tonight. Emphasize early detection. Certainly emphasize some prevention measures, which we don't have a lot of data on, but we know, and make sure that we're taking part of what we talked about here today. So, Dr. Stern, thank you again. Yes, I'm turning back to you. I think you have something you want to share.
So I just want to issue a call to action, if you don't mind. And my call to action is Suffolk County. Situation in Black men is not great anywhere in Massachusetts or nationally. And so we created Prostate Cancer Equity Program to make sure that men have the best experience and the best doctors for their care. We are very concerned about Suffolk County because it has such unacceptable mortality statistics. So please come to AdMeTech Foundation. You will be educated and taken care of by me, by Ron Green, who is present here today, and by Tricia Kinney. And we will work with our clinical colleagues in leading academic institutions in Massachusetts, including Dr. Basin, to make sure you will be taken care of every step of the way. If you are 40 years or older, if you have any questions about screening, if you have any concerns about being recommended to and being referred for biopsy or treatment, if you have any complications of treatment, please do not hesitate to come to us. Email coordinator at admetechfoundation.org. We will be able to help. Help is here. Thank you so much. I hope everyone will have a great evening.
Thank you.
Thank you so much.
Thank you.